Welcome back, focused learners. Today, we're diving into an incredibly fascinating, complex, and honestly super impactful topic, short bowel syndrome. Let's jump right into this explainer. Our goal today is to break down exactly what happens when the human gut loses its absolute most vital asset, its surface area. I want you to imagine a sudden, massive disruption to the body's baseline. What actually happens when a large portion of the intestine is surgically removed? Well, the body immediately loses its ability to absorb essential nutrients, maintain baseline hydration, absorb life-sustaining vitamins, and really just sustain normal metabolism. It's a profound physiological shock. And the consequences? They are immediate and they are severe. Here's how we're going to map out this disruption arc today. 1. Anatomy of normal absorption. 2. Causes of bowel shortening. 3. Pathophysiology and clinical impact. 4. The intestinal adaptation process. And 5. Modern medical management. Part 1. Anatomy of normal absorption. Establishing the baseline. You know, the gut isn't just some generic tube. It's a meticulously zoned factory. The duodenum, that handles iron and calcium. Then you've got the jejunum, which is the absolute heavy lifter for carbohydrates, proteins, and fats. And down at the end, the terminal ileum has very specific, non-negotiable jobs, absorbing vitamin B12 and recycling bile salts. If you lose just one of these zones, you literally lose its specific function.
Moving on to part 2, causes of bowel shortening, the inciting events.
So, how exactly does a patient lose these vital zones? Well, surgical resection is the most common path, but the underlying reasons differ drastically depending on age. In adults, we're frequently seeing resections due to Crohn's disease, mesenteric ischemia, severe abdominal trauma, radiation enteritis, or a volvulus. But in the pediatric population, the inciting events are usually things like necrotizing enteral colitis, congenital intestinal atresia, or midgut volvulus. The severity of the outcome ultimately depends heavily on the exact length of the intestine removed, what sections remain, and whether crucial checkpoints, like the colon and the ileocecal valve, are still intact. Regardless of the cause, when a massive resection occurs, we arrive at our core definition. Short bowel syndrome is a malabsorption disorder caused by the extensive loss or dysfunction of the small intestine. I really want to hit hard on that word, malabsorption. Fundamentally, this is a severe disorder where the body simply cannot take in what it needs to survive. Part 3. Pathophysiology and clinical impact, the biological fallout. Okay, so the absolutely crucial point here is this overriding equation. Decreased intestinal length equals decreased nutrient absorption. It's simple, brutal math. Less surface area directly equals less absorption. Literally everything else we're about to discuss stems from this one central loss of surface area. Let's trace a specific cause and effect chain to see how this plays out clinically. Remember the terminal ileum's job? If the terminal ileum is removed, we immediately get decreased bile salt reabsorption. Without those bile salts around to help digest fats, fat malabsorption shoots up. Clinically, this presents as steatorrhea, bulky, greasy stools. And that fat malabsorption triggers another kind of crazy secondary cascade. Because fats aren't being absorbed properly, they stay in the gut and bind to calcium. Normally, calcium binds to oxalate, keeping it from being absorbed. But with the calcium busy binding to all that unabsorbed fat, free oxalate is rapidly absorbed into the bloodstream, and that ultimately leads to the formation of oxalate kidney stones. On top of that, the bile salt abnormalities we just mentioned, they can also lead to the formation of gallstones. It's a total domino effect. Let's quickly fire through the rest of the systemic fallout, because there's a lot. Massive amounts of unabsorbed fluid lead to severe chronic diarrhea, causing immediate dehydration and plunging electrolyte levels. The loss of that terminal ileum, that triggers a critical vitamin B12 deficiency, causing neuropathy and megaloblastic anemia. We also see a profound drop in the fat-soluble vitamins, A, D, E, and K. And interestingly, the stomach often overcompensates post-resection with gastric acid hypersecretion. This actively worsens the diarrhea and damages digestive enzymes. The whole shebang culminates in severe malnutrition, muscle wasting, fatigue, and edema. Part 4. The intestinal adaptation process. The body's attempt to fix it. This incredible process is called intestinal adaptation. The remaining bowel literally changes its own structure to save the host's nutritional status. It compensates through villus hypertrophy, which means the absorptive fingers of the intestine actually grow taller and thicker. It increases its overall absorptive capacity, and it intentionally slows down transit time to give itself more time to extract nutrients. Pretty amazing, right? Let's see how this builds over time, because it is definitely not an overnight fix. In the days immediately following a resection, the primary issue is just massive fluid loss. Over months, that crucial villus hypertrophy and adaptation begin to really kick in. And for years, these compensatory structural changes can continue. It is a marathon of physiological remodeling. Part 5, Modern Medical Management, Medical Sciences Support. We have to define the ultimate clinical endpoint for the most severe cases out there: intestinal failure. This occurs when short bowel syndrome is so profound that the patient simply cannot maintain their nutrition or hydration through eating. They absolutely require intravenous support just to sustain life. Management starts by directly countering those pathophysiological dominoes we talked about earlier. We use small, frequent meals packed with high complex carbohydrates. We aggressively replace fluids and electrolytes. We use antidiarrheal drugs like loperamide to slow transit. We bring in proton pump inhibitors like omeprazole to suppress that massive gastric acid hypersecretion. And of course, we meticulously supplement vitamin B12, fat-soluble vitamins, and minerals. For those in true intestinal failure, total parenteral nutrition, or TPN, becomes their absolute lifeline. It's an intravenous nutrition matrix. But we have to be completely transparent here. It is a heavy intervention. Long-term use of TPN carries severe risks, including devastating liver disease, serious catheter infections, and bone issues like osteoporosis. Now, what's really fascinating is how modern medicine is actively trying to help the body heal itself. Enter tecaglutide. This is a GLP-2 analog therapy. It's a hugely important hormone treatment that medically accelerates and enhances the body's natural intestinal adaptation process, actively promoting intestinal growth. It is a real game changer for many patients trying to reduce their dependence on TPN. And for patients who suffer from refractory failure despite TPN and pharmacotherapy, maybe their liver is failing due to the TPN itself, intestinal transplantation remains the final, incredibly complex surgical option. All right, for all you focused learners out there, let's cement these high-yield exam pearls. You've got to memorize these. The most important function of the terminal ileum: vitamin B12 and bile salt absorption. The major symptom of this syndrome: chronic diarrhea. What does fat malabsorption cause? Steatorrhea and oxalate kidney stones. The major nutritional support for ileus failure: TPN, and that important hormone therapy that promotes growth: tegaglutide. Lock those in. As we wrap up this explainer, I want you to take a second to reflect on this quote. Short bowel syndrome is a powerful example of how essential the small intestine is for human survival. Losing intestinal surface area isn't just an anatomical change, it severely disrupts nutrition, metabolism, and really the overall quality of a patient's life. But as we've seen today, the body's sheer ability to adapt, combined with incredible multidisciplinary medical care, allows so many patients to achieve remarkable recoveries. Which leaves us with a final thought. With modern therapies like GLP-2 analogs enabling such incredible recovery, how will future treatments further revolutionize care for intestinal failure? Thank you so much for joining me on this explainer. Keep asking questions, keep learning, and I'll see you in the next one.